Thank you all for coming here to listen to West Nile virus, and really, you know, the star of the show is not Karen or myself, it's that lady sitting in the back who's lived the West Nile experience. So what I'll do is just start off by giving you a basic overview about West Nile virus, talk about the epidemiology of it, the clinical manifestations, and you know, we've done, a group of us at McMaster have done some work in West Nile, so I'll show you some of our data, and then we'll speak to Connie, and Karen will go over the mechanisms of disease. So I'll just start off with the first slide. Well, as you can see here, West Nile virus is a Flavivirus. There are about 70 members, and these are RNA single-stranded viruses with an envelope, and they're spread either by ticks or by mosquitoes. They've got their genome here can be looked at in terms of the structural and non-structural coding components, including the capsid, membrane protein, the envelope, and all the sort of non-structural genes. The basic cycle of the virus is that the virus is basically amplified through birds. It's spread by the Culex mosquito, as you can see here, and it used to be thought that sparrows and crows were the greatest amplifiers, but in fact it's actually robins. Robins are what we need to worry about in terms of the spread in terms of efficiency. Humans and other mammals tend to be bridge hosts. We're infected, we're not part of the natural cycle, but unfortunately we sometimes get disease. The virus was first isolated in 1937 from a febrile patient in Uganda, and since then it became endemic and widespread across tropical parts of Africa, southern Asia, northern Australia, and episodic in more temperate parts of Europe. So the bottom line was, originally up to the 50s or 60s, it was felt that this was a relatively benign infection. People would have a mild illness or be asymptomatic. Then there were a number of outbreaks in Europe and in the Middle East where the severity came through. In fact, there is circulation of the virus in Africa, where a high percentage of people have antibodies, but not really much disease. This slide just shows the outbreaks of West Nile, outbreaks in Israel, France, South Africa, Romania, Italy, and Russia, and with, you know, I'd say moderate to sometimes severe illness. And the story for us, and really where the sort of epidemiology, the research, more studies about the clinical manifestations really came forth starting in this outbreak in New York City in 1999. This was a major outbreak centered around sort of Queens and a bit sometimes severe illness. You know, I'd say moderate to, and the story for us, and really where the sort of epidemiology, more studies about the clinical manifestations starting in this outbreak in New York City. Patients really came forth as a major in 1999. This outbreak around sort of centered around sometimes severe illness. You know, I'd say moderate to Queens and a bit, and the story for us, and really where the sort of epidemiology, more studies starting in this outbreak about the clinical manifestations really came forth as a major in 1999. This outbreak in New York City around sort of centered around sometimes severe illness. You know, I'd say moderate to Queens and a bit, and the story for us, and really where the sort of epidemiology, more studies starting in this outbreak about the clinical manifestations really came forth as a major in 1999. This outbreak in New York City around sort of centered around sometimes severe illness. You know, I'd say moderate to Queens and a bit, and the story for us And really, we're the sort of epidemiology studies starting in this outbreak. More patients really came forth is about the clinical manifestation. It was a major in 1999. This outbreak found sort of break in New York City, centered around, I'd say moderate to sometimes severe illness and a bit of and really, and the story for us, studies starting in this outbreak, more the sort of epidemiology is about the clinical manifestation. It was a major patients really came forth outbreak around sort of break in New York City in 1999. This centered around sometimes severe illness, I'd say moderate to and really, and the story for us, starting in this outbreak, protecting their arms and their legs, were at higher risk, not unexpectedly, of getting infected with West Nile virus. This slide is from a paper in a relatively recent paper in Science, just sort of summarizing the spread of West Nile throughout the Americas. There's not data here from. It's just centered on the Americas, and you actually see the sort of westward trend of West Nile. So you can see years of West Nile virus detection, and as it gets darker, you could see the trends are more recent. This slide looks at the relative number of neuroinvasive cases by the years from detection of West Nile virus in that state. So what it shows is that relatively recent cases, you see a greater proportion of neuroinvasive cases as time goes on. The proportion of cases that are neuroinvasive diminishes. So in terms of the burden of diseases between 1999 and 2010, approximately 1.8 million people were infected, with approximately 360,000 people who developed illness, and over 12,000 reported encephalitis and meningitis, and over 1,300 deaths. There have been a number of studies looking at risk factors, and I think just overall they're relatively poorly defined. They're not really good methodologic studies using high numbers of patients to say, okay, what are the risk factors? But generally speaking, people who are older tend to be at higher risk. There is a study from Alberta that compared cases of West Nile in a transplant population to estimates from the population, and they found that the risk was about 40-fold in terms of people who were immunosuppressed. So being older, having something a little wrong with your immune system are high risk factors. There's a group in Texas that found that hypertension seemed to be a risk factor. I personally don't really believe this because it hasn't been replicated in our data or others. So, but from sort of the average individual's point of view, many people don't have risk factors. So the typical person is someone who might be in their 40s or 50s who was relatively active, was exposed to mosquitoes, and all of a sudden their life just turned around, and I think Connie will discuss this in more detail, her own story, but really, really, really terrible sort of progression sometimes, and without immune suppression or age, and we'll talk a little bit about what genetic variants might be at play, but again, it's been very, very hard to sort that out. In terms of the routes of transmission, as I've mentioned, mosquito bites is the most common, but it's also been transmitted through transfusions, and as a result of that, there have been large, sort of sustained large effort to actually protect the blood supply by screening donors for West Nile using PCR. It's been transmitted through organ transplantation, through crossing through placenta, and even through breast milk. So in terms of the clinical syndromes, the majority of people who get infected really won't even know it. They have no symptoms whatsoever. Okay, 20% get something called West Nile fever. They develop sort of like fevers, chills, maybe some joint pains, maybe a rash, sort of just like a flu-like illness that's self-limited. 1 in 20 of those individuals, however, goes on to worse disease, and these are the individuals that we're concerned about. They develop meningitis, encephalitis, or West Nile virus polio-like syndrome called acute flaccid paralysis. Some of these individuals clinically can develop signs of Parkinson's. That's usually temporary, although it's been described for up to a year and a half. And one question is will there be sort of a post-Parkinsonian syndrome which could occur years later? It's been described, and since the outbreak began in 99, 2000 in the Americas, we're getting to a point where it might be, we'd have to keep our eye out for people who might actually be developing Parkinson's as part of this sort of post-Flavivirus encephalopathy. And individuals also, it's potential, there are post-polio syndromes that have been described, and it's possible up to about 10 to 15 years after being infected, that individuals get sort of a degeneration of their lower motor neuron fibers, and as a consequence might get an exacerbation of what their initial presentation is. They initially presented with acute flaccid paralysis. Maybe they got better. There's a potential for worsening in the future. Again, it's sort of unknown territory, but I think at this point we really have to be thinking about that and looking at this carefully. And I was thinking this morning, it might be not a bad idea to actually do some sort of survey in people who are newly presenting with Parkinson's disease anywhere from now or in the next 5 years, and actually doing antibody testing to see, were they actually exposed to West Nile virus. This slide just summarizes the diagnostic criteria. So West Nile meningitis is, clinical signs of meningitis. People get nuchal rigidity, they get photophobia, they present with sort of a really bad headache and fever. So when we're doing sort of clinical studies or trying to capture this, we make up these definitions. So clinical signs of meningeal inflammation, and one more of the following. So either high or low fever, cells in the spinal fluid, peripheral white count over 10, and sometimes with meningitis, we might, if we do a CT scan or an MRI, the radiologist might interpret it as being compatible with inflammation of the meninges. West Nile virus encephalitis is sort of a worse presentation because people come in with an encephalopathy, so they might be confused. They have sort of clouding of consciousness. Some are in stupor. Some might even be in a coma. And often they will have the similar findings, either hyper or hypothermia, cells in the CSF, and compatible imaging either on MRI or a CT scan. They might have focal neurological deficits, seizures, etc. The virus does tend to like the basal ganglia. They could get, again, as I mentioned, Parkinson's symptoms that could actually be transient, and at times they can actually persist. So acute flaccid paralysis is actually one of the worst presentations for patients. It's acute onset of limb weakness. Again, it's a pure polio-like syndrome with progression for over 48 hours. They might have two or more of the following: asymmetric weakness, areflexia, absence of pain, paresthesia, numbness. They might have cells in the CSF, elevated protein, high peripheral white count, and imaging, that is MR or CT scan, and also EM&G findings that are compatible with destruction of lower motor neuron or damage to an anterior horn cell. In terms of lab diagnosis, PCR is generally a good test. It's highly specific. Sensitivity is low mainly because of the timing. There's just a very few days, there's a sort of relatively narrow threshold where the patient is viremic, so it might be hard to pick up. The most common test is an IgM, so the initial immune response. That's about 90% sensitive up to day 8 of illness, but the problem with it is sometimes it can persist for up to 500 days. So if you have a patient with a positive IgM, it could be that they were previously infected and now they're presenting with something else like a stroke. ELISA is not so good a test. It's got a low specificity because of cross-reactivity with other flaviviruses, so it could react with dengue or Japanese encephalitis virus. The definitive serological test is to do plaque reduction neutralization tests. Okay, so that's where we get blood at the very beginning of a season if we're following a patient, and at the very end, and if they get a 4-fold rise or more with this, and it actually is a test that shows neutralization of the virus, so it's very, very specific for flaviviruses. This slide just shows you the viremia and antibody response. The incubation period ranges from 3 to 15 days, so roughly up to 2 weeks. Then there is a viremia that occurs, and as I mentioned, there's a relatively narrow threshold there. A person gets ill, so the virus is sort of in the blood a day or two prior to illness. After onset of illness, there's that IgM, and that's what we use to make the diagnosis, and eventually they'll be switching to an IgG response. So in terms of prognosis, there have been, I don't know, probably 5 to 10 groups that have been that have done studies to look at this. We did probably the largest study because at the time we thought, well, no one really is actually tracking patients and seeing how they're doing. No one is actually using standardized tests. So, we decided to do this and to try to make it as rigorous as we could. So we enrolled 156 participants. Half of them were female. The mean age was 52 years, but they ranged from 19 to 85 years. Again, it's unusual to have people that young develop symptoms with West Nile, and if they're going to get disease, usually they get West Nile fever, and that was that case. Most of them, as I mentioned, were very healthy, no pre-existing comorbidities. About 14% had some comorbidity. The most common was pulmonary, either chronic obstructive pulmonary disease and more commonly asthma. So what we found in our cohort was there were 64 participants who had neuroinvasive disease. Okay, so 22 had encephalitis, 32 had meningoencephalitis, so they had sort of combination. 3 we'd say pure meningitis, and 7 had acute flaccid paralysis. Okay, so there were too few people in this group to study. So most of what I'm alluding to now is people who are less severely ill. Although these patients are severely ill, these are the ones who are affected the most. So we followed these folks. Okay, and we also followed the folks with non-neuroinvasive disease, those that had that sort of like flu-like illness. There were 5 participants with neuroinvasive disease that died. Okay, so that's an obvious selection bias in our sample, right? Because we want to track what's going on. So the people who were doing well, who survived, were the ones we followed. So one could argue that there is a selection bias here, and that's obvious. So 1 person with acute flaccid paralysis, 3 with meningoencephalitis, and 1 with encephalitis died. 24 were admitted to hospital. Median length of stay was 7, but range up to 32 days, and 7 had to be admitted to the intensive care unit. And some of these patients had encephalitis. They all either had some encephalitis, and 1 had acute flaccid paralysis, and there was no one with non-neuroinvasive disease, that is, just with West Nile fever, that died or even required hospital admission. So the bottom line, I'm not going to go into much detail on these graphs, but they're basically are the summary of our data. When these graphs go up, it means if you've got a bigger score, you're doing better. Here, if you're getting a lower score, you're doing better. But the bottom line is these curves are comparing people with neuroinvasive or non-neuroinvasive disease, and they were very similar, okay? So similar at about 1 year. So what we found is that about 1 year, most individuals had physical and mental functioning that were in the population norms, okay? The problem with it, the limitation, is that we didn't have their own functioning at baseline because we saw them when they were ill to begin with, okay? But it gives some reassurance to some people to say, okay, well, if you've got this at about 1 year, we could say that if we do these standardized tests, you'll be similar to the population. And it worked the same way whether we looked at meningoencephalitis or meningitis, okay? The problem with this is that we didn't capture a lot of things. So there are a number of patients, you know, every 2 or 3 weeks sometimes I'll get an email from someone that says, you know, I got West Nile virus, you know, 5 years ago, and I've never been the same since. And we started a pilot study with a neuropsychologist doing a detailed battery of tests, and there are a lot of, they're subtle, but they're there. I think we had about 25 or 30% had either moderate to severe neuropsychological impairment. So there's a lot of things that are going on that we didn't capture. Okay? Now, on the other hand, there are a lot of people who will email me and say things, and then, you know, I can say, well, it doesn't sound like though that's related to your West Nile virus, because things happen over time, right? So it's sorting out, is there something that's persisting in these people that's not described, or is it, well, they happen to have West Nile virus and they're getting something, you know, a complication that has no bearing whatsoever. This slide just looks at stratification by comorbidities, and it just shows that those individuals at a comorbid feature did, you know, had a harder time getting back to normal. And those individuals, actually, when we looked at mental functioning, it was tougher on women. The women had a harder time getting back to their baseline, and those individuals who had comorbidities also had a harder time getting to baseline in terms of mental functioning. This is a slide, so I mentioned to you that I didn't include those 7 individuals with acute flaccid paralysis because we didn't feel there was enough data. So this is a slide from CDC where they looked at following people from sort of baseline over time. So these were people who had the poliomyelitis, and they found basically that 1/3 of individuals did better over time, so that they were okay, they went close to baseline. 1/3 somewhat, and there was 1/3 that really did not improve. So it's really variable in terms of what happens over time with function. Another study that we did was, this was funded by the NIH, to look at genetic variants, because I mentioned to you that, you know, most people don't get affected by it, but a small proportion really get sick. So and I'm not going to go through all the genetic studies that have been done, but our hypothesis was that West Nile virus is a consequence of genetic factors that result in increased replication, subsequent pathology. So we went through cases in Canada, in the United States, cases of neuroinvasive disease, and we compared them to cases that had mild non-neuroinvasive disease. And we did genotyping. We looked at over 13,000 single nucleotide polymorphisms, so 6,000 genes, and then after that we used a larger chip, over 1 million SNPs. So we really did a whole genome association study, although we weren't actually powered for a whole genome association study, looking for any variants that were associated with neuroinvasive disease. And although we got some preliminary data, some data suggesting that there are some variants that could be important, we haven't replicated those, okay? But we found that something called RFC1, replication factor, it's been shown to be essential for coordinated synthesis of DNA strands, for simian virus replication. So this had a positive association. Sodium channel neuronal type 1 alpha subunit. Again, this variant has been associated with various neurological entities like epilepsy, febrile seizures, etc. And ANPEP that serves as a receptor for human coronavirus. So all of these, you know, suggested are potential candidates for a genetic cause. So I'll wrap up by just talking briefly about therapy and prevention. And in terms of therapy, it's relatively simple. If you're a practicing physician, there is none. Okay, so there is no therapy that has been proven. So there have been a number of possibilities that have been studied. Ribavirin, which can be used for RSV, was tested in one outbreak in Israel where the death rate was about 40% in treated patients, so it's not very promising if you're using it during an outbreak of West Nile and people are dying at a very high rate. Interferon alpha, which one would think because of its inducing an antiviral state might have an effect. No effect whatsoever in a randomized controlled trial for Japanese encephalitis virus, so that lowers the possibility that it might have an effect for West Nile. siRNA is an interesting type of therapy. You need an effective delivery system, so that's probably the thing that's holding it back. There have been inhibitory peptides studied in animals, no human studies, aminosugars that inhibit endoplasmic reticulum host enzyme, and there have been some hits through high throughput screens in animal models, but nothing that's really made its way to humans. In humans, the most promising therapy is monoclonal antibodies, so high neutralizing activity in vitro and provide really good protection in vivo. So in some studies, mouse or humanized antibodies, when they were given as a single dose 5 or 6 days after infection, 90% of mice or hamsters were protected. So acute flaccid paralysis was also blocked by treatment with one neutralizing monoclonal antibody. So there's been a phase 1 or 2 randomized control trial that sort of demonstrated some safety, nowhere efficacy. They didn't actually enroll the number of people that they needed. So it's ongoing, but that's probably where the direction of future therapy is heading. In terms of prevention, there have been a number of candidates that have been included, like DNA vaccine, the Kunjin virus, recombinant West Nile envelope protein, but really the one that's gone furthest is a chimeric vaccine that uses the backbone of a yellow fever vaccine genome and uses sequences to the envelope and the membrane protein. So there have been studies here showing pretty robust T-cell, CD8 T-cell response detected after up to 1 year after vaccination, and really good antibody responses. But that's sort of the state of the art. So the vaccine story is still unfolding. And I believe that was my last slide. So I'm not sure, do people start with questions now, or do we just run through?
As you like. We can, if
okay.
There's any questions, we can take
well,
the questions are not recorded.
First, I just emailed Connie. Connie, come down and just tell us your story, okay? So maybe that's what we'll do, and maybe we'll let Connie in her own words describe her experience.
Mm-hmm. Okay, as you know, my name is Connie. I live in the Niagara region here in Ontario. I got the West Nile virus in September 2005. I've been suffering with this for 7 years. The beginning of it occurred when I started getting very, very tired symptoms. It only lasted 2 days. The third day, I got excruciating pain to the side of my head, not knowing what it was. So my husband was with me and he asked me if I was okay, and I thought, whoa, that really hurt, but I don't know what it was. Within about 15 minutes later, I got another sharp pain to the left side of my head. I was done. I was still at home. My husband was looking after me. I do not recall anything after that last pain.
Connie, I'm going to interject.
Yep.
What, did the pain go anywhere? I'm just going to like pretend I'm a doctor.
Yeah.
Which
no.
I am, but
yes.
So
I'm the patient.
Did the pain go anywhere, or did it just stay there?
Just in the head.
Just in the head. And what kind of pain was it? Was it like dull or sharp, or?
I described it as, now, this is my only way of explaining it. Somebody had a voodoo doll and just sticking a knife right through my head.
Okay. Okay.
That's all I could. It was very, very intense.
Okay.
So apparently I was still at, like a lot of this stuff I don't remember, I'm going to try to help. I was still at home, getting worse by the day. The pains apparently, I was complaining they were getting worse. Nausea was starting. So my husband took me into emergency. They checked me out. For some reason, with what my husband told them, they actually thought I had the West Nile, but they had to confirm it. So they gave him painkillers, sent me home. The Friday, so about 5 days after all this had happened with the head pain and all, I guess I said to him, it is time for me to go, because he'd been wanting to take me to the hospital. So, brought my bucket, carried me in his arms, did not call 911, took me to the hospital. They tested me. Next thing you know, I woke up 2 months later. They diagnosed me with the West Nile 8 days later, as you were saying on that one part. And 24 hours after they hospitalized me, apparently that's when I flipped into the coma. I stayed into a coma for approximately 9 days, which they had just gotten the results. That's what I had. I was on feeding tubes, trachs, respirators. I had 24-hour nursing care right by my bed. Then it came up that it was this West Nile. Well, they couldn't move me because they couldn't stabilize me. I don't know what was going on in the head or whatever, but so apparently the doctors from Hamilton, they were all notified by phone and through Dad and that. Toronto, London, Welland, St. Catharines worked together to try to bring me back. In the meanwhile, my family was called in 3 times because they were losing me. So then they come up with this idea, and I don't know if even you heard of it, Dr. Loeb. They wanted to zap me with the highest strength that a body could take in steroids, because they had tried everything else and nothing would bring me out of it. Within 4 hours, I guess my body was trying to move. So once I came out of the coma, I do not remember anything till mid of November. So I come out of the coma beginning of October, do not remember a thing. When I woke up, I was laying in this bed, perfectly still. I tried to communicate to my husband, and I couldn't speak. I couldn't move. There was nothing. The only thing was eye contact. That was the only thing I could do. So then the nurses started coming in my room with books. My husband brought pictures. They wanted to get the brain working again. So I did. I came along. I was in ICU in Welland for 2 months, just out on the floor for 1 week. Then they transferred me to Hotel de Shaver in St. Catharines to a rehab center. When I got there, I was totally paralyzed from here down. They looked at me, had no clue what they were going to do with me. They weren't familiar with the West Nile all that much either. So they worked with me. It took 3 people to sit me up, 3 people to dress me, because I had nothing. And it was about the beginning of January, because I went to Shaver beginning of December. Beginning of January, I was in physiotherapy, and their question was to me, Connie, what do you want to accomplish out of this? So now I'm in speech therapy, and I'm trying very, very hard to communicate with the people over there. And I got it out, and my son was getting married in July. So that was my goal, to achieve walking even 2 steps. So they released me from the hospital after 4 months being there, but the therapy continued. As far as I'm concerned, the encephalitis has caused major damage, even up till today. If you tell me to push an object, I will pull it. If you tell me, okay, Connie, we're going to go down the stairs, you'll see me at the top of the stairs many, many times going, it will not transfer the message right away. I was still going for therapy up until last year. I had to leave because my husband got sick. But I'm back in at Shaver, and we're still trying more things again. And they've been amazing.
So have you found, so you with the physical therapy, you found you've been improving quite a bit?
Not quite a bit.
Or do you think your sense is more time?
Yeah. Yeah. But it's giving me more encouragement to try, even myself, to understand what's going on.
Yeah. And in terms of is there any specific one problem that's the worst, you know, maybe for your functioning or anything like that?
Yes, it's affected my right side. That's why I've got my cane with me today. I always have it.
Yeah.
And my right arm. You will see me move it, only the shoulder doesn't work. I've had very, very weakness. It gives out several times. But
Yeah. And what about your just mental processes and thinking, and how is that, have you been affected that way? Or
that was a very hard one to explain to people, because I would always say, oh, I don't remember. And that's the way I always put it forward. But to give you an example, a few years ago I was at my son's, just standing there watching the kids play in the pool. I moved to the right of me. Just part of my foot would move. The toe stayed on the ground. Down I went. I had no control. I don't think the brain was sending the message, because I just went, uh-oh, and down I went and broke the arm. 3 months ago, I broke my hip. All through, it's not communicating to me to move those parts, to, you know, how to handle. And that's the hardest. And it's getting worse.
it's getting worse to be, you're functioning in some ways, yeah.
When I try to explain, I forget things. People say, oh, we all do. We all forget stuff.
Yeah.
But I wasn't communicating properly for them to understand what I was trying to tell them.
Yeah.
Now that they know me more and been with me, now they're starting to understand.
Okay. 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 Thank you. Okay. All right. Well, do we have any questions for Connie? Anybody has any questions to ask?
Do you have control over your bladder and
No. No. It's affected a lot of core muscle.
In terms of the ICU, I mean, that's, you know, I mean, I overall, although you still have a lot of problems, you've made tremendous progress.
Absolutely.
And I guess part of that was just your goal to get better.
That's correct. Yep.
Okay.
Yep. My husband took a year off of work to be by my side, just to watch through everything I was in, how to take care of me at home, because I went home in a wheelchair. And my family, my friends have been great supporters.
Yeah.
Oh, yeah. Absolutely great.
And I think prior to this, you were very healthy, right?
I was.
There was
Yep.
very
I walked
active.
2 hours a day. I was swimming in the pool, biking an awful lot.
Yeah.
Yep.
Yeah, you see.
And I was a believer in the spray. And there was the odd time I didn't spray.
Yeah. Do you remember the time where you don't
No.
you don't remember exactly
No.
when you were bitten, eh?
Nope.
No.
I know it was around home, but that's it.
Okay. Sorry, there's a question.
Connie, thank you for coming in.
Thank you.
Are you on any specific medications or treatments right now?
Actually, the only thing I'm on now is antidepressants to get me through this. That is it. Yes.
Hi, Connie. Thanks for
Hi.
coming in. I was just wondering, you mentioned that when you first went in with your headache and you had some nausea, I believe they already had suspected West Nile. Did you have, I know you don't remember that well, but do you, anyone tell you about any other symptoms you might have had or any further testing might have done to think that you had West Nile originally?
When I went to the hospital,
Yeah.
all I know is my husband told me they ran all kinds of tests and blood work, and it would take 8 days to know these results. But I left out one little piece. When I had the head pain, like I told you, that afternoon before the pain started, something was going on in my body, and I didn't know what it is. I felt like my arms had pins and needles in them. And I told that to my family, told it to my husband. Of course, we didn't know what it was. But now I'm thinking maybe it's because of the nerve damage to the brain. I don't know. But both arms were just covered with pin needles.
I mean, typically the way, you know, Connie, when you're presenting, the way that it usually works is people take a history and a physical exam, and when in a case when there's a neurological symptom, the whole exercise is to pinpoint what part of the brain, what part of the nervous system has been damaged, right? So we do that by taking a history, looking at gait, looking at strength in the upper and lower extremities, doing cranial nerves tests. We will just do like this. I don't know if I should do a neurological exam.
No, don't.
I might get criticized, but
They did that to me in Welland.
yeah, so
Now that
do
you
it like
say
a
that,
neurological exam and check the reflexes, and then the whole exercise is to say, that's what neurologists do. You know, unfortunately, they don't offer their patients a lot, but they could tell them what's wrong with them, right? They could say, where is the lesion, and then what is the lesion? That's neurology. Where is the lesion? What it is. Sorry, there's not much more we could do with it. It's not entirely true, but to a certain extent it is. So they would have done the physical examination. They would have seen, you know, if you could walk, they would have done the gait, they would have checked that, and they would have said, well, this is where we think the lesion is. That would have been step number one. Then they would have looked at blood tests. They would have done a CBC, and they probably would have seen an elevated white blood cell count. They would have done a CT scan of the head to rule out a bleed immediately, because a bleed is a neurological catastrophe. You have to get the blood, evacuate blood out, or else, you know, someone can die very rapidly. So they would have done that, and if there was no bleed, they might have been too early. Typically it's too early. Sometimes you have to repeat the CT scan to see where the damage is. They would have done a lumbar puncture, and likely, in your case, they would have found high protein cells, maybe 200 or 300 cells, lymphocytes mainly, and a normal glucose. This is sort of a fairly typical type of situation. The MRI, they would have followed with an MRI and would have showed in the, you know, sort of parenchymal sort of damage. This is sort of typical findings. Yeah, so in the differential, there would have been bacterial meningitis. You'd presented. We would ask, is this a viral meningitis or viral meningoencephalitis? So, you know, is it West Nile? Is it a herpes virus? Because if it's a herpes simplex virus, we could use acyclovir. So typically, you would have been treated with acyclovir empirically, that's without any diagnosis, and probably put on antibiotics for bacterial meningitis until your diagnosis of West Nile virus became positive. And the primary therapy, as I was mentioning, is that there is really nothing. Maybe these monoclonal antibodies can work, but the monoclonal antibodies would have to be given really early, and to actually study if they work is very difficult, right? Because in our study, sometimes it takes time because we have to get consent from patients. So it's not like someone walks into St. Catherine's emergency room and someone says, I think it's West Nile, can we just give them monoclonal antibodies? We have to contact the physician, get the okay from the physician to approach the patient. Some physicians, you know, aren't interested or whatever, and the delay ends up to be weeks to months. So it becomes very, very hard to do sort of a real-time, even a trial of monoclonal antibodies. It becomes really, really difficult unless, you know, you have buy-in sort of across the board. And yeah, and in terms of support, it's, again, as you mentioned, occupational and physiotherapy.
Now that you say that, I remember my husband saying when they first brought me to the hospital, which probably answered that gentleman's question even better, apparently they sat me on the bed and the doctor in the ER said, now this is what my husband, because I was out of it, okay? Touch your nose. Exactly what you just said.
Right.
And I guess I did it 3 or 4 times, and I said, okay, I did it. And the doctor said, do a couple more, let's see what happens. As soon as he said that, I was like this. Everywhere but on the nose. Yeah, I remember
Right.
my husband telling me that, yeah.
Okay.
Well,
Okay. Yeah.
What's the typical protocol if a patient like that comes into the ER and someone suspects that it's some kind of, you know, for example, if it's West Nile virus, Connie, you were sent home?
yes.
Yeah. Is that typical for a patient to be sent home?
Well, not if they're comatose. I could guarantee that.
Yeah.
But
Yeah.
maybe Niagara. Just kidding.
No.
No, it's not. It really depends how ill they are, right? So that's the role of the emergency physician. They have really one role in life, is to figure out whether someone could leave the hospital or be admitted, you know, and to stabilize them, right? So if someone comes in and they have like a flu-like syndrome, and it could be West Nile, and they don't think it's bad, they don't think it's a meningitis, they well could be sent home. If they come in, you know, really with confusion and their vital signs are all out of whack, they won't. But it's the severity of presentation that dictates what happens to people.
On top of that, I did walk in that Wednesday night when they just gave me meds and sent me home. I don't remember though, but apparently I did. But then when he brought me back 2 days later in his arms, they moved real quick.
Yeah.
Yeah. Mm-hmm.
How did your husband or your family describe the time period that you can't remember? Were you like mentally active to them? Like what was your response to whatever was going on?
My response, once I knew what was happening, my response was, I remember looking over to, this is just a little story, remember looking over to my husband who had been sitting in the chair for who knows how long. I didn't even know how long I was sitting there for. And I was trying to communicate with him saying, not what was wrong with me, what did I do to you? It really frightened me. I knew I couldn't move from head to toe and I was frightened to death. And that's, yep.
So the question was the symptoms of, you mean like the acute flaccid paralysis? Yeah, but usually it will occur initially. You know, if someone has acute flaccid paralysis, it'll occur initially over days. It'll evolve, right? So it's not like they're gonna be well for 2 months or whatever. They'll have something. The question we don't know about is whether years, 10 or 15 years after, let's say someone has made progress with the poliomyelitis, whether it'll come back because of degeneration of the nerve. So it's a denervation problem. Okay, so that was described with polio. 20 years after the fact, people get worse. Okay, it hasn't been described yet in West Nile, but the thinking is because this is a polio-like syndrome, for the people who had that presentation, it might well happen. Okay, and the question that I think is okay, what is the mechanism? Should we be looking at that now? So I was thinking this morning, should we actually be going to the Toronto Western and actually doing antibody studies? Toronto Western, because they have a lot of Parkinson's cases, newly diagnosed case of Parkinson's. Should we actually be looking at antibodies of for West Nile and say, well, if that's the case, okay, why is this happening now? Are there mechanisms? Are there immune mechanisms? That relate to this? And one way to sort of that out would be to actually compare those people who have this post-polio syndrome to those who don't, and actually do perhaps immune studies to actually see whether there's something there immunologically. I don't know, but that's what I was thinking of this morning. Yep.
I have two kind of related questions. Do you agree with the use of high-dose steroids in a case like this where you have a comatose patient with West Nile? And secondly, how do you distinguish West Nile infection to a patient that may have had West Nile in the past that has like a post-viral immune-mediated encephalitis?
Well, the first question is there's no evidence that steroids will work for West Nile, right? So, and Connie, when you got sick, you were more in the early days. No one would advocate using steroids now. If empirically someone comes in with meningitis and you think it's bacterial meningitis, then steroids are part of the cocktail you give. If someone you think someone has pneumococcal meningitis, bacterial meningitis, you will give the proper antibiotics and steroids, because there's some evidence that that'll reduce the rate of complications. Not so for West Nile virus. Steroids would not be implicated whatsoever. Okay, so you wouldn't need steroids. Now the second question is, how do you know whether if someone is coming in with an acute presentation, whether
Rather than the issue being an actual infection with the West Nile virus, having a post-infectious immune-mediated encephalitis.
A post-infection immune, well,
Where the immune system is more the problem than the actual virus.
Right, right. Well, first of all, in terms of the pathology, we don't know. It might well be the immune system that's the problem at the very beginning, okay? So we don't, there's no, it might well be part of not replicating virus, but the immune system itself is the problem that's causing the damage, okay? The things that I was talking about is the, you know, the post-encephalitic syndromes or whatever. Those happen years after the original infection. So that's Parkinson's disease, you know, a Parkinson syndrome getting worse over time, years after, or a polio syndrome. But that's about it. The damage happens, you know, pretty shortly after a person is infected. Okay, well, if there aren't any other questions, we'll go to Karen and Connie. Thank you very much. Let's have some applause. Connie, too.